My name is Professor Raman Bedi. I'm an emeritus professor at King's College London and chairman of the Global Child Dental Fund. We're really delighted today to have an excellent speaker, Dr. Mas Ahmad, who's at the University of Technology, Mara in Malaysia. Dr. Mas, welcome.
Thank you.
On the panel, we have Dr. Jacob Johns and Professor Callum Durward. Jacob Johns at the University of Malay, and Callum Durward is at UP in Cambodia. The topic today is the management of medically compromised dental patients, and the purpose of today is to give an overview of this subject area. Dr. Mas, we invite you to give your lecture.
Hello, everyone. My name is Dr. Mas Ahmad, and I am a specialist and associate professor in special care dentistry at the University of Technology, Mara, Malaysia. I am going to present an overview on the management of medically compromised dental patients. So the objective of my lecture today is to discuss the multiple aspects in patient care that you need to consider when you manage a patient with medical complexities, especially in a general dental practice setting, and what are your roles as a general dental practitioner. So there are so many medical conditions, but I am just going to highlight on those that you may encounter in your dental office, especially those patients who require multidisciplinary intervention. So I will start with patients with psychological disorders. These are some of the common psychological conditions which you may encounter in your dental office. These conditions may be exacerbated by a visit to the dentist or creates problems during consultation or treatment. When treating patients with psychological disorder, the responsibilities of dentists include to ascertain that the patient has adequate control of the disease process and to be alert on the development of any oral effects of the disease or medications and to manage this appropriately. So these are the issues in managing patients with psychological disorders, which I will discuss. The first one is mental and systemic health status. Take accurate medical history. Obtain the specific diagnosis. Consult with your medical counterparts to assess control of the psychiatric disorder, the current status and psychological profile, patient's current medication regimen and potential drug interactions, any other therapies that the patient may go through, as well as the degree of compliance with pharmacological therapy and other treatment. Liaison with the medical and other healthcare team members is also useful when planning for dental treatment. For example, in the need to prescribe for medications to reduce anxiety or other strategies such as hypnosis, cognitive behavioral therapy, and relaxation techniques. One of the potential side effects of antidepressant and antipsychotics is xerostomia. Xerostomia can also be stress-related. These are the common oral health sequelae of dry mouth. And because of the increased risk of developing oral diseases, plan for a rigorous oral hygiene preventative regimen, which includes management of dry mouth. Review the patients regularly. Refer to oral medicine specialists if there's an evidence of oral mucosal lesions or pathology. Next, I would like to discuss on patients with intellectual disability or behavioral difficulties. Issues in managing patients with intellectual disabilities or behavioral difficulty include management of their oral health problem, cooperation issues, and difficulty in maintaining oral hygiene care, which have all been previously discussed by previous speakers in depth. Gingival hypertrophy, bleeding, and oral infections are common, associated with the use of anti-epileptic medications. In this case, good oral hygiene control is important. Is there any possibility to change the drugs to different medications with less side effects of gingival hypertrophy, then you can discuss this with a medical doctor. If the gingival hypertrophy is severe, then a referral to the periodontologist can help with reducing the patient's gingival hypertrophy. Other problems include caries and periodontal disease. These are associated with poor oral hygiene care, xerostomia, sugar in syrup medications, oral risk factors, and unhealthy dietary habits. Liaison with the patient's occupational therapist, pharmacist, and dietitian can help the patients in maintaining good oral hygiene care. Another common presentation is maxillofacial or dental alveolar trauma, which can result from self-injurious behavior, temper or tantrum, and epilepsy. Referral to pediatric or restorative dentists or endodontists, as well as oral maxillofacial surgeons and oral medicine specialists, when required, is advised. Next, I would like to move on patients with conditions affecting mental cognition or neurological functioning. Patients under this category include Parkinson's disease and stroke. Parkinson is a neurodegenerative disorder characterized by tremor, muscle rigidity, bradykinesia, akinesia, postural instability, and gait disturbance. Whereas stroke happens because of disruption of blood supply to the brain, either by a clot or ruptures, leading to death of brain cells within minutes. Maintenance of oral hygiene care is important. Liaison with the patient's caregivers, nurse, and occupational therapists may help in planning for the patient's daily oral hygiene care. Alzheimer's is a neurodegenerative disorder that affects memory, thinking, and behavior. So for these patients, they would have problems with communication, compliance, and cooperation with daily oral hygiene and professional care, consent taking, as well as side effects of medications. So find out which medications they are taking and its potential side effects. Plan for preventative care and detect any oral health problems for management and referral. In addition, find out about their dietary requirements. Some of these patients are fed with high calorie, high sugar content food. Some need to take small, frequent meals throughout the day. And some with dysphagia may require modified diet or are tube fed. All of this can predispose patients to high risk of oral diseases if oral hygiene is not maintained. Next, I will discuss on management of patients with immunodeficiency disorders. Conditions that can cause profound immunocompromise include end-stage renal disease, end-stage liver disease, malignancies, untreated or end-stage HIV infection, malnutrition, as well as conditions treated with immunosuppressive therapies, such as those with autoimmune and inflammatory conditions, organ transplantation, and malignancies. One of the things to consider in managing these patients is the risk of infection. Indications for antibiotic prophylaxis should be made in liaison with the medical counterparts. It depends on individuals' treatment needs, degree of immunosuppression reflected by the level of neutropenia, general health condition, oral hygiene status, and prior history of antibiotic therapy. It is suggested that absolute neutrophil count of less than 500 cells per microliter is a sign of severe neutropenia. For patients on corticosteroid therapy, seek for medical advice regarding steroid supplement. The need for steroid supplement depends on the complexity or invasiveness of dental procedure, overall health of the patient on exogenous steroids, as well as the amount of endogenous cortisol produced during physiological response to stress. Please check your local institution's guideline on recommendations for steroid supplement. In Malaysia, the recommended guideline is if the patient is currently on prednisolone of 10 or less milligram per day for 3 or more weeks, no supplement is required, plus local anesthesia, plus post-operative pain control. However, if the patient is on more than 10 milligram per day for more than 1 week, either no supplement is required, plus local anesthesia, plus post-op pain control, or to double the dose of steroids on the day of procedure, depending on patient's anxiety level. We are to monitor patient's blood pressure, heart rate, and pulse. If the patient was previously on steroids for more than 3 weeks and has stopped taking it for 3 or less months, treat patient as number 1. If they have stopped taking for more than 3 months, no supplement is required. If the patient is undergoing minor surgery under general anesthesia, patient is to be given 100 milligram hydrocortisone intramuscular pre-op and to maintain usual glucocorticoid medication. If the patient is undergoing major surgery under general anesthesia, patient is to be given 100 milligram hydrocortisone as bolus pre-operative and 50 mg 8-hourly for 48-hour post-op. Other aspects of dental management of patient on corticosteroid therapy include to conduct dental treatment in the morning, to have a responsible adult for at least 12 hours post-operative, and to control anxiety, stress, and pain through pharmacological and or non-pharmacological intervention. Adrenal crisis is an emergency condition that can happen to the patient, described as progressive hypotension that can happen in 6 to 12 hours after dental treatment, where the patient experiences faint, confusion, hypothermia, nausea, vomiting, gastrointestinal cramps, and collapse. The next condition I would like to highlight is HIV. For HIV patients, we are to find out patients' CD4 cell count, viral load, the use of HAART or antiretroviral therapy, and the presence of oral cardinal lesions. An increased viral load indicates either that the patient's infection is getting worse or that the virus has developed resistance to HAART. Viral loads that are consistently less than 200 copies per milliliter indicates that virus is adequately suppressed and that the risk of disease progression is low. It is also recommended to perform liver function tests, complete blood count, and coagulation profile due to the adverse effects of HAART. For HIV patients undergoing invasive dental procedure, if their CD4 cell counts is less than 100 cells per millimeter cubic and patients are on long-term antiretroviral chemotherapy, they should be evaluated for neutropenia. If the patient's absolute neutrophil count is less than 500 cells per millimeter cubic, they should receive antibiotic prophylaxis before dental therapy. Assess whether there is a state of anemia or thrombocytopenia and work with your medical counterparts to ensure that the delivery of treatment is in a safe and effective manner. Dentists should also look for cardinal signs of HIV infection. These include candidiasis, oral hairy leukoplakia, linear gingival erythema, acute necrotizing ulcerative gingivitis or periodontitis, Kaposi sarcoma, and non-Hodgkin's lymphoma. Other oral lesions associated with HIV include warts, recurrent aphthous-like ulceration, and oral herpes simplex in either the form of primary herpetic gingivostomatitis or herpes labialis. Next, I will discuss on patients with renal failure. For these patients, there is an increased risk of infection. There is also an increased bleeding tendency. There's also a decreased ability to excrete drugs. In this case, please liaise with nephrologists when prescribing medications. Avoid nephrotoxic drugs such as aminoglycosides and tetracycline. The recommended antibiotic is amoxicillin or clindamycin, whereas the recommended analgesics are paracetamol, codeine, morphine, fentanyl, and to avoid aspirin and NSAIDs. Renal osteodystrophy is a condition that results from altered mineral metabolism, leading to bone defects, fracture, pain, and calcifications of joints, including TMJ. There is an increased risk of fracture during extractions. Oral health complications include uremic stomatitis, oral mucosal bleeding, petechiae and or ecchymosis, as well as calculus formation and extrinsic staining. For patients with renal failure, consult the patient's nephrologist to determine the state of disease, treatment, medical complications or comorbidities, whereas there is a need to adjust medications, and also the best time for dental treatment. For patients with liver failure, identify which disease the patient is currently diagnosed with. If hepatitis B or C, make sure that strict cross-infection protocol is practiced. The occupational transmission of hepatitis B is 3.3 to 30% compared to HIV, which is 0.3%. Drugs metabolism may also be affected. Consult doctors when prescribing. Avoid chloramphenicol, erythromycin, and tetracycline. The use of analgesics, which is paracetamol, of less than 2 grams per day is safe, and other analgesics to be used include tramadol 25 mg 3 times a day. There is a risk of bleeding because hepatocytes are involved with the synthesis of factor 5, 7, 9, 10, 11, 12, protein C and S, fibrinogen, prothrombin, and antithrombin. Liver sinusoidal endothelial cells also produce factor 8 and von Willebrand factor. Liver failure can lead to low production of coagulation factors and reduced production of thrombopoietin, leading to decreased central production of platelets within the bone marrow. Therefore, conduct coagulation screen such as bleeding time, prothrombin time, and APTT to assess the need for hospital referrals for factor and platelet transfusion. Make sure we apply hemostatic measures and to avoid aspirin and NSAIDs. Specialist advice for surgery is required, especially in a jaundice patients, as some patients need their fluid and electrolyte balance to be corrected. Last but not least, patients with bleeding disorder. In Malaysia, patients with bleeding disorders are to be managed in a hospital setting by the dental specialist. This is because dental specialists may need to liaise with the patient's hematologist to assess the risk of bleeding and undertake the necessary preventive measures or manage complications that can happen. It is important that a thorough medical history is obtained from patients to ease the referral process. Acquiring the accurate diagnosis is important to identify the risk of bleeding and intervention required. However, patients may come to your clinic with bleeding and requires emergency intervention. So what you can do is to consult with a dental specialist or OMFS surgeon and identify the source of bleeding. The most common causes are dental extraction, gingival bleeding, often due to poor oral hygiene, and trauma. Local treatments must be considered to treat the hemorrhage, and these may include direct pressure on the area using a damp gauze swab and maintain for at least 15 minutes, to suture, to close the wound, application of local hemostatic agents, the use of antibiotics, especially in gingival bleeding due to poor oral hygiene, as well as the use of tranexamic acid as a mouthwash. The Irish Haemophilia Society has come up with a comprehensive guideline on emergency dental treatment during COVID-19 pandemic required by people with inherited bleeding disorder. You can download this guideline to find out more from the website. To conclude, I would like to highlight the important role of dentists in the multidisciplinary management of patients who are medically compromised. Dentists should work with other members of the healthcare team to ensure that treatment is delivered in a safe and efficient manner. Multidisciplinary intervention also involves those within the dental team itself, consisting of dental assistant, dental nurse, dental technicians, and other specialists. So thank you, everyone. Please contact me for any inquiries or for future collaboration, especially in the area of special care dentistry. Thank you.
Dr. Mas, thank you so much for that. That was an excellent lecture, really comprehensive, and gave us some great insights into how we manage medically compromised dental patients. I'm just going to open this up to the panel for any questions or any comments. Jacob, can I start with you?
Thank you, Prof. Raman. Thank you, Dr. Mas, for the excellent lecture. And it's very, very easily understandable for young graduates as well as young dental students. I just want to ask you now, normally when we talk about behavior management, it is the pediatric dentists who teach that. And then you have specific requirements, you know, where we follow the protocols. Now, when it comes to adults, how is it the same, or how is it different from what we teach in pediatric dentistry?
Thanks, Dr. Jacob. Good question. Actually, first of all, what I always do is I look at what the patient needs. So, and what they like and what they don't like. And how I do this is by talking to the parents. So by asking their parents what they usually do in other settings, for example, when they go for their medical checkup, when they get their vaccination, so I can get an idea of what are the strategies that we can emulate on these patients when they come for dental treatment. So most of the time, it's always about the same things as what we apply on our pediatric patients. For example, distraction, positive reinforcement. So I would say it is not much different, but you need to assess the patients individually, because different patients have different requirements. They have different likes and dislikes. So I would say that yes, it is very much the same as the pediatric patients. It's just that sometimes asking the parents would be very, very useful. And sometimes we just have to mix and match and try and error, because in one visit they like one approach, and the next time they come it doesn't work anymore. So it's very much try and error as well. So and if from my clinical judgment, if we have to apply pharmacological intervention, then we will work with the patient's medical counterparts to decide on what is the best approach. Is it sedation or is it general anesthesia? So yeah, I hope that answers your question.
Thank you. I suppose that gives more confidence for the young dentist, because you know, it will be a challenge when they come up with an adult, because they are lost thinking that, you know, that's the behavior management is something else. And so thank you for that.
Yeah.
Okay.
Actually, the parents can help a lot. I learn a lot from the parents actually. So they come with all these tips and tricks that you can try while they're on dental chair. So yeah, talking with the parents a lot help a lot.
Good. Thank you. Callum, any comments, questions?
Yes, thanks very much, Dr. Mas. That was a great lecture. Sometimes I think when dentists have to treat a special care patient, sometimes they look at their medical history and they immediately feel feelings of anxiety and fear. Perhaps this is something they haven't come across before. They may feel they don't know a lot about that medical problem or that disability and so on. And that tends to make them not want to treat the patient. It puts them off. Do you have any tricks or any suggestions about how the dentist can approach that and rationally look at, you know, the medical problem perhaps that they have and what they should do, so that because often they can do something and they don't always need to refer the patient to somebody else, but they may just lack that confidence.
Yeah, even as a specialist, I do experience that sometimes, especially if the patients come with a syndrome which I have not heard of. And there's so many syndromes out there. And to be honest, I'm still learning, because no surgeons can have seen it all. Like there's a saying, right? So usually for my patients, the day before they come for the appointment, I will usually call the parents first and ask about the patient's medical conditions and relevant history, and I will do some reading about that condition. But if the patient just turn up in my clinic, then you know, it's not wrong for you to open up Google and have some information about it, because it's not, well, the parents are actually very, very supportive. They won't feel surprised that you have not actually heard about that syndrome. And the fact that you put the initiative to open up Google and read about it, so it means a lot to the parents actually, that you actually put in some effort to learn about the condition and find a way to help their child. So to answer that, number one, prepare the day before, or if you can't prepare the day before, it's okay to read up about it in front of the parents itself. And sometimes the parents themselves can tell you information such as, oh, my child have he had been treated under general anesthesia all this while. So then you have an idea that, okay, there was a history of dental treatment being done under general anesthetics, and there is a possibility that you need another GA for this patient. But again, communication with the parents. And also I communicate a lot with my medical counterparts as well. The pediatrician, the rehab medicine, they are very, very willing to share their knowledge. And especially with regards to prescription of medicine, I consult a lot my anesthesiology colleagues, my clinical pharmacologists, to ask for the opinion about drug prescription for a certain condition. So multidisciplinary intervention is the key. So it's okay if you don't know. This is when you work together with other members of the healthcare team to decide what is the best for the patient. So after consultation, then you have an idea whether this patient requires referral to the specialist, or the patient is better treated in a hospital. So contact your colleagues, your medical colleagues, your allied health colleagues, get some information about it, and then collectively discuss to decide on what is the most suitable and appropriate management for these patients. So yeah, that's my opinion.
Thank you.
Thank you. Dr. Mas, I think I agree with you that the World Wide Web has a lot of information, but my personal experience is that there's nothing more valuable to a general practitioner than being able to pick up the phone and talk to a specialist. And I think actually one of the value of having specialists is not only that they provide great service and high-level services to the patients, but also they can be supportive of general practitioners directly. So, and I just wonder whether because Malaysia has so many specialists in special care dentistry as opposed to a number of other countries, I just wondered whether you found that to be a reality in Malaysia, and maybe could sort of signpost us on the need for that in other countries where there are no specialists.
Yeah, in Malaysia, the Ministry of Health Special Care Dentistry team has set up a teledentistry service. So they are open to referrals and discussion of cases. And in my case, because I have close contacts with all the special care dentistry specialists in all the other institutions, so I just pick up my phone and call them, and they're very, very accommodating. So there are things that we can't learn from textbooks, but through experience. Yeah, and because they have seen so many patients, we share experience, we share tips and tricks, and I find it very, very useful. And with the establishment of the teledentistry, I think that is great. It should be implemented worldwide.
Yeah, no, I think digital health in general is very, very good. And you're right. I think the most valuable thing is the mobile phone. So that gives us access to it. I just want to ask you about caregivers. You mentioned parents already, but caregivers are not always easy to engage for. And I just wondered whether you have some insights of how we could better engage with caregivers on oral hygiene, on diet, etc.
Yeah, there are some very helpful, enthusiastic parents or caregivers, and there are also some who do not put oral health as a priority. And this is especially difficult for example, separated parents, and they can have conflicting decision. So I suppose public health education is important. So this is when public health specialists play a major role. So like Prof. Callum. So first of all, we need to instill that awareness that we can help them. There are services out there that can help their children. So once they develop that that awareness, it can then they will feel more willing to bring their children to us. So that's why, again, multidisciplinary intervention, in which case I work a lot with my public health colleagues, trying to convince the community, the public, that oral health is important, and there are services out there that can help them. So yeah, public health education.
Good. That's been really insightful, actually. You've given us, I think, for all the dental students who view this and general practitioners, some really good tips and insights into how to manage medically compromised dental patients. So we want to thank you for that, want to thank you for your lecture, and we look forward to working with you in the future. So thank you very much.
Thank you.